Hey, welcome back to Not So Complicated, and it's day 6, clinical case discussion 6. We are doing the series, and here is the question. A 42-year-old female presents to the clinic with a 3-month history of palpitations, weight loss 8 kg despite increased appetite and intermittent double vision, diplopia. And she reports heat intolerance, excessive sweating, and a noticeable neck swelling. It may be the disorder of thyroid, obviously. And she denies recent infections, trauma, or medication changes. Past medical history includes vitiligo and a family history of autoimmune diseases, mother with rheumatoid arthritis. She is a non-smoker with no alcohol or illicit drug use. So vitals, hypertensive, she is systolic hypertensive, 140 by 80 mmHg, and heart rate is 110, which is increased and is also irregular. Respiratory rate is normal, SpO2 normal, and temperature is also normal. On examination, she is restless, moist skin, and fine tremor. And in hint examination, there is a proptosis bilaterally, lead lag, diplopia on lateral gaze. She has thyroid eye disorder, and it is a case of Graves' disease, maybe, yeah. And 3cm firm thyroid nodule, right lobe on tenderness, no tenderness. And in cardiovascular examination, there is irregular rhythm and no murmurs. Abdomen is soft, non-tender, and there is no organomegaly. And skin is patchy, deep pigmentation, vitiligo, pretibial myxedema. And the labs, TSS is very low, and free T4 is increased, and also free T3 is also increased from the normal range, and TSI is positive. So TSI positivity is obviously a case of Graves' disease, but still we will debunk each of the options and eliminate other options like why they are not the right answer. We will debunk, we'll discuss each of these cases. And it is in ECG, she is present with atrial fibrillation. There are anti-TPO antibodies also elevated, and ultrasound shows 3 centimeter solid thyroid nodule, increased vascularity, no lymphadenopathy, and a RIO scan is diffuse uptake, 45% at 24 hours, normal 10 to 30%, right? So what is the most likely diagnosis and what is the next step in management? Graves' disease with toxic nodule. Second option is Hashimoto's thyroiditis with transient thyrotoxicosis and papillary thyroid carcinoma with hyperthyroidism, and then subacute thyroiditis, maybe decurvens thyroiditis, and also multineural toxic goiter. And let's debunk its options, right? And the first option is Graves' disease with toxic nodule. Here is the case recap in the upper region. And the Graves' disease is an autoimmune thyrotoxicosis, obviously, and it presents with lower TCS, elevated free T4 and T3, which are the case in this clinical scenario, and also palpitations, weight loss, heat intolerance, and tremors, ophthalmopathy like proptosis and diplopia, and pretibial myxedema, TSI positivity, all are the features of Graves' disease. And the high radioactive iodine uptake, which is 45%, confirms increased thyroid activity typical of Graves. And this explains the firm nodule and sustained symptoms. Atrial fibrillation results from thyroid hormone excess, and mild hypercalcemia 10 to 8 mg per deciliter reflects increased bone turnover. And anti-TPO antibodies are often elevated in Graves'. Anti-TPO is anti-thyroid peroxidase enzymes, right? And vitiligo aligns with the autoimmune predisposition, and also family history of autoimmune disease is there. And the nodule's presence complicates the picture, distinguishing it from classic Graves', but ultrasound and radioactive iodine uptake findings align with the hyperfunctioning nodule within a Graves' context. We will also discuss about the management in later slides, but we will first debunk each of the slides in here. And the photo attached in here reveals all the symptoms with a typical female, for a typical female with Graves' disease. And these are muscle wasting, fine hair, muscle wasting due to high metabolic rate, basal metabolic rate increases maximal, and also fine hair and exophthalmos, goiter, sweating, tachycardia, high output failure, and weight loss, oligomenorrhea, tremor. These all are the cases, symptoms of thyrotoxicosis. And the second option we had is Hashimoto's thyroiditis with transient thyrotoxicosis. And Hashimoto's thyroiditis is a chronic autoimmune thyroiditis, causing hypothyroidism due to lymphocytic infiltration and destruction of thyroid tissue. And since lymphocytic infiltration can cause transient thyrotoxicosis due to the breakage of thyroid follicles and thyroid cells, and the loss of release of hormones in initial phase, so it causes transient thyrotoxicosis, right? And elevated anti-thyroid peroxidase antibodies can occur with vitiligo or family history of autoimmunity. And in the early stages, a transient thyrotoxic phase, which is also called hacetoxicosis, may occur due to follicle destruction, as I talked about it earlier. And also, this phase lacks Graves-specific features such as proptosis, diplopia, pretibial myxedema, or thyroid stimulating immunoglobulin positivity. Since Hashimoto's thyroiditis is a typical case of hypothyroidism, but it also has transient thyrotoxicosis due to this reason. But even if it has thyrotoxicosis, it lacks the features like proptosis, diplopia, and all other ophthalmopathy, right? And in many patients remain asymptomatic in Hashimoto's thyroiditis. Nevertheless, the Hashimoto's thyroid disease symptoms can be early ones, which may include difficulty in passing stools due to constipation and fatigue, dry skin, also increased in weight due to decreased basal metabolic rate. And as the disease progresses, the patient might encounter a few symptoms of hypothyroidism, such as intolerance to cold, peripheral neuropathy, and decreased energy, depression, loss of memory, joint and muscle pain, hair loss, apnea, menorrhagia, and voice hoarseness due to goiter enlargement can occur, because the goiter enlargement compresses our larynx and thus recurrent laryngeal nerve, to be specific, and it causes voice hoarseness in the hypothyroidism case in Hashimoto's thyroiditis. And the third option we had is papillary thyroid carcinoma with hyperthyroidism. Papillary thyroid carcinoma is the most common thyroid carcinoma or tumor, often presenting as a palpable nodule. As seen here is 3 centimeter nodule, and it is solid. It can coexist with Graves' disease, and hyperthyroidism may occur if a nodule is autonomously functioning, which is toxic adenoma. However, PTC itself rarely causes thyrotoxicosis, and features like proptosis, diplopia, obviously, and TSI positivity are specific to Graves, not cancer, because cancer has its one specific tumor markers, right? And FNA, fine needle aspiration, is needed to exclude malignancy. The nodule may be incidental or functional, but cancer alone doesn't explain the full picture. And even if the cancer alone doesn't explain this full picture, we have to do FNA to exclude malignancy at any cost, right? And the slide attached in here is microscopy of papillary thyroid carcinoma, and it shows papilla with fibrovascular core, right? And samoma bodies are the classic features of this papillary thyroid carcinoma on microscopy. And also in details, the papillary thyroid carcinoma can be categorized in 4 different types: PDTC and PTC tall cell variant, and PTC columnar cell variant, and PTC hobnail variant. We can see here in the slides the histology of all of these cases. And in first type, there is solid trabecular architecture in red color and blue colors in there, and they lack nuclear features of PTC, and at least one of the following 3 features are seen: mitotic index at least 3 per 10 high power fields, and tumor necrosis, convoluted nuclei should be there. And PTC tall cell variant, there should be greater than 30% of tumor area contains tall cells, right? And tall cells cell height is 2 to 3 times of its width. That is what tall cell criteria is. And other useful features are elongated tram track follicles, which is high yield for USMLE and also for PLAB, and oncocytic cytoplasm and distinct cell border are seen. And in PTC columnar cell variant, there is prominent pseudostratification and elongated nuclei. Nuclear features less developed. And in PTC hobnail variant, there are greater than 30% of tumor area contains hobnail cells. Hobnail cells, what are hobnail cells? These are apically located nuclei. These cells have apically located nuclei. High nuclear to cytoplasmic ratio, papillary or micropapillary architecture. And in radiology, we can see a prominent nodule in here. In radiology, it is a right lobe nodule in radiology, and also the pathogenesis or the prognosis of this, the metastatic features of this tumor is that if the tumor has capsular invasion in 21 to 58 percentage. Tumor shows extrathyroidal extension in 11 to 48 percentage. Lymphoid node metastasis in 14 to 64 percentage, and there's a distant metastasis in 2.4 percentage. Distant metastasis often involves brain, which is almost 18 percentage rate, and in lungs 49.1 percentage, and in bone 24 percentage metastatic rate is there. And also the fourth option we had is subacute thyroiditis, which example is decurvence thyroiditis, is a post-viral inflammatory condition causing transient thyrotoxicosis. Because if you have a viral infection, then the post-viral inflammatory condition can cause transient thyrotoxics due to thyroid hormone leakage from damaged follicles, right? And then it presents with painful thyroid enlargement, fever, and elevated erythrocytic sedimentation rate 30 mm per HR. Here is borderline, HR means hour, and followed by hypothyroidism and recovery. Thyrotoxicosis mimics Graves' low TSH, high T4, T3, but radioactive iodine uptake is low in the case of subacute thyroiditis, which is less than 5% due to suppressed thyroid uptake, unlike the high 45% is in the case here. This is the distinguishing point here from Graves' disease to subacute thyroiditis. And the patient also has no thyroid tenderness, fever, or recent viral illness, and features like proptosis, diplopia, pretibial, myxedema, and TSI positivity are absent in subacute thyroiditis. These are the very most distinguishing features. We do not have confusion here. We shouldn't have any confusion. And the 3 centimeter nodule and 3-month symptom duration suggest a chronic process, not transient inflammation. And TPO may be mildly elevated, but TSI is specific to Graves', and this is the case unlikely. And numerous granulomas are seen in histology in subacute thyroiditis. Also, colloid field follicles and lymphocytic infiltration and destroyed follicles can be seen in here, right? And the fifth option we had is multinodular toxic goiter, but since there is 3 centimeter one single nodule, it is not a case of multinodular toxic goiter. We can exclude it in one single information, but still let's debunk it. MNG causes thyrotoxicosis from multiple autonomous nodules overproducing thyroid hormone common in iodine deficient areas or older adults. In iodine deficient areas like Himalayas, if a case presents a patient from Himalayas, then we can say that he is in iodine deficient condition, and it presents with low TSH, high T4, T3, and symptoms like palpitations or weight loss, but lacks autoimmune features, TSI, and TPO, proptosis, pretibial myxedema. I'm repeating all of these symptoms all over again because we have to remember this, right? And we are remembering this with concepts. And radioactive iodine uptake is elevated with focal hot nodules. And if hot nodules are seen in USG or radiology, then we can say this is multinodular toxic goiter. That is also a high yield typical feature and not diffuse uptake. This patient has a single 3 centimeter nodule, which excludes this option obviously. And there we can see the things about multinodular toxic goiter. The primary factors are familial goiter, or genetic markers and other genes, right? Genetic markers are TG and MNG1, and decreased inhibition of the TSS producing pituitary cells can also cause multinodular toxic goiter. And secondary factors are low iodine intake, smoking, natural goitrogens like cabbages, cauliflowers, and certain drugs can cause these things. And also the diagnosis is Graves' disease. Our diagnosis is obviously Graves' disease, and the mechanism of pathophysiology of Graves' disease is that B cells release thyroid stimulating immunoglobulins, and those TSIs activate thyrotrophin receptors, and that lead to the release in high T4 and T3, which suppresses the TSH. Also, that is why the lab findings are high T4 and T3 and low TSH, and markers are TSI and TPO, and this causes hyperthyroidism. And also retroorbital fibroblasts, T cells produce inflammatory cytokines, and they increase glycosaminoglycans and anti-orbital muscle antibodies. That is why ophthalmopathy is present in Graves' disease. And in clinical features, we can see these eyes, the lead lag in here, the proptosis in here, and we cannot see diplopia, because that is a feeling that patient experiences. And also the signs and symptoms of Graves' disease are frequent bowel movements, to GI hypermotility, obviously, which will cause to diarrhea, to weight loss despite increased appetite due to increased metabolic rate, and shortness of breath due to increased metabolic rate, obviously, and heart palpitations due to sympathetic nervous system activation, insomnia, fatigue, muscle weakness, hand tremors due to SNS activation, obviously, and increased perspiration, heat intolerance, and decreased attention span, anxiety. And all of these are the symptoms of Graves' disease, you can see. And also the management of Graves' disease is multifocal. We have to do the interdisciplinary management. The first are antithyroid drugs, right? And initiate methimazole 15 to 30 mg daily, titrated based on free T4 or T3 every 4 to 6 weeks to inhibit thyroid hormone synthesis. And we have to monitor for agranulocytosis and hepatotoxicity, which is the side effects of methimazole. Agranulocytosis can cause fever and sore throat, and propylthiouracil can also be used as 100 to 150 mg TID is an alternative if methimazole is contraindicated, but it's less preferred due to higher hepatotoxicity risk. And we have to continue until euthyroid case is achieved. Typically 4 to 8 weeks it takes. And also we have to use beta blockers, start propanolol 20 to 40 mg TID, or atenolol 25 to 50 mg daily to control tachycardia, palpitations, and tremors. And propanolol also reduces to T4 to T3 conversion. So T3, which is the active form of thyroid hormone, also decreases and taper once heart rate normalizes and thyroid levels stabilize. And the table here presents us that differences between propylthiouracil and carbimazole, and dose to dose less potent is propylthiouracil, highly plasma protein bound, less transferred across placenta and in milk. So in first trimester we use propylthiouracil, and in thiouracil, and in carbimazole we use in late pregnancy. Larger amounts cross to fetus and in milk, so that is why. And the plasma T-half level of propylthiouracil is 1 to 2 hours. Carbimazole is long acting, 6 to 10 hours. Single dose acts for 4 to 8 hours in propylthiouracil. There is no active metabolite, and multiple 2 to 3 daily doses needed. Inhibits peripheral conversion. This is the benefit over carbimazole, which that is it inhibits peripheral conversion. And also the management, we have to manage atrial fibrillation, that we have to continue beta blocker, atenolol preferred for atrial fibrillation to maintain HR less than 100 beats per minute. And if it is inadequate, we have to add diltiazem 120 to 240 mg daily for rate control. And also anticoagulation, we have to assess CHA to DS2 BASC score. We will talk about that later. And likely greater than 2 because age is 42, female, hypertensive. And we have to initiate apixaban 5 mg BID or warfarin INR 2 to 3 to prevent thromboembolism given AF duration is less than 3 months. If AF persists greater than 48 hours, transesophageal echocardiogram to rule out thrombus before cardioversion should be done. And cardioversion should be done if atrial fibrillation persists after euthyroidism 4 to 6 weeks. Consider electrical cardioversion or amiodarone under cardiology guidance, right? And there is CHA to DS2 BASC score. It is the score for risk factor, is stroke risk score for patients with atrial fibrillation. This is the case of cardiovascular system, but I have put it here, attached here, because it is reliable in here. And C for congestive heart failure or left ventricular ejection fraction less than 35%, which is index point. Index score is 1. Right. And hypertension, as for hypertension, 1, age greater than 75 years, 2, and diabetes mellitus, 1, stroke TIA, systemic embolism, 2, and vascular disease, if there is any myocardial infarction or peripheral arterial disease, aortic plaque, it is 1, and age 65 to 74 years, 1, sex category, if it is female, then 1. Moderate to high risk is if there is greater than 2 score, and low risk if there is 0 to 1 score. That is what CHA to DS2 BASC score. And also we have to address about ophthalmology, ophthalmopathy. We have to address mild symptoms using artificial tears and selenium 100 mcg BID to reduce inflammation. And also we have to elevate head of bed to reduce periorbital edema. And moderate diplopia should be managed by referring to ophthalmopathy ophthalmology for prism glasses or possible steroids. Prednisolone 20 to 40 mg daily 4 to 6 weeks if progressive, and we have to monitor for optic nerve compression. And smoking cessation, counsel against smoking. Patient is non-smoker as it worsens ophthalmopathy. In Graves' disease symptoms, there is a comparison between Graves' eye disease and thyroid eye disorder and normal. We can see all of that in there. All of this is a high yield, right? And we have to evaluate nodule to fine needle aspiration, perform FNA biopsy of the 3 centimeter solid nodule to rule out malignancy given size greater than 2.5 centimeter and hypervascularity. So Bethesda classification guides next steps, which is attached in right side, the Bethesda classification. You can read that. And also the functional assessment should be done if nodule is hyperfunctioning, suggests autonomy, but coexisting Graves complicates interpretation. If FNA is benign, then treat as part of Graves hyperthyroidism, right? And the definitive therapy of Graves disease is radioactive iodine. Iodine 131 preferred for Graves with toxic nodule, and we have to administer 10 to 20 mci iodine 131 after methimazole. Stop 5 to 7 days prior to ablate hyperfunctioning thyroid tissue. And post-treatment, we have to expect hypothyroidism due to this treatment, and also we have to start levothyroxine 1.6 mcg per kg per day once TSH rises. Contraindicated in moderate to severe ophthalmopathy, risk of worsening, use with caution given diplopia. And also thyroidectomy can be done. Consider if I131 is declined, nodal FNA suspicious, or ophthalmopathy is severe. We have to do total thyroidectomy, requires lifelong levothyroxine, and risks hypoparathyroidism or recurrent laryngeal nerve injury, refer to endocrine surgery. And long-term monitoring, if methimazole is continued 18 to 24 months, monitor TSS free T4 T3 every 3 months for re-emission, and relapse requires iodine 131 or surgery. That is all for our today's case discussion. It got longer, right? And okay, subscribe for our next case discussion, and thank you for listening and staying with me. And also comment if you have any recommendations. Yes, thank you.